Great. Awesome. So we are continuing our journey in learning more about the community health worker benefit. In case this is a service that your organization would be interested in implementing for you all to kind of on some level sustain your services, especially services that pertain to health navigation, health education, screening, and any type of individual support that you all provide for your clients and patients. So today we'll be focusing on the standing recommendation policy and how that works in practice. And we're also going to talk about the outreach and referral process. And so we're kind of getting to the nitty-gritty of the everyday practice of CHW services and how the policies translate into everyday practice. And we're going to skip these intro slides. You already know who I am and my colleague Joanne. We're really just continuously feeling really grateful for the opportunity to work with Alex and Min at the LGBTQTA Center to deliver this capacity building service for all of these fabulous grantees that are noted on this screen. On this particular slide, you'll see a tailored list of modules, training modules that we have proposed for this these webinar series. And we've completed module one, where some of you participated in learning more about what does the PAVE application entail, what does the managed care plan readiness assessment and the credentialing process look like. So we talked about that. We recently talked about community health worker qualifications for the CHW benefit and the training requirements, and we provided a tool in terms of how you can start mapping out your documentation kind of requirements to measure CHW qualifications. Actually, come to think of it, I'm not sure if we actually shared the exact tool itself. We provided a template, but I don't think we've disseminated a tool yet for this group. And then today we're talking about the standing recommendation policy and what that looks like in practice, and the referral and outreach process, especially when you're working with your managed care plan and a licensed provider, whether that's, in-house at your organization or whether you're partnering with another organization. So this is the module that we'll be focused on today, module 3. And these are our proposed learning objectives. So today, we're hoping that folks will be able to explain the standing recommendation policy for CHW services, including the eligible member criteria, the Medi-Cal member criteria. Hopefully, you'll be able to articulate the annual service authorization limits, the supervision requirements, and documentation standards. Secondly, we're hoping that by the end of this webinar or this conversation, we can identify some outreach and referral strategies to recognize eligible members and to establish partnerships, whether it's in-house or outside your organization with licensed providers. And then we'll navigate a couple of referral pathways and apply them appropriately to connect your members with CHW benefit services. So how does this sound in terms of learning objectives for Amber and John?
It sounds great to me.
Okay,
One
great.
thing I want to add is, maybe these were sent to me. I would love to be able to, I'm sorry I missed the first couple. I would love to be able to go back and see those recordings. So if there's a link to those, I would love to be able to go back and review them.
Yes, definitely. I can share that
Thank
with
you.
you, John.
Okay.
Great. Thank you so much, Min. And John, no worries about the missing the first two. If you ever want to set up a one-on-one call to discuss the first two topics, Joanne and I are more than happy to make yourselves available. And
Okay.
so I know for Joanne on this call, she'll be taking notes and tracking kind of action items and tasks. So Joanne will we'll follow up with John shortly after today's call. And Min, thank you for sharing
Thank you.
the recordings. Yeah,
Oh, thanks, Min.
yeah, great. So this is the flow of the conversation that we'll have. First, we'll go over the standing recommendation policy. We actually have a case study example that's tailored for this group. And then we'll go through the referral and outreach workflow, and then we can have a discussion just continuously throughout the webinar. So just unmute and or raise your hand or drop in the chat box at any time. Just interrupt me, whenever you would like to share something. Um, so we'll go on to this case study here. And this case study was developed by our team, trying to think through thoughtfully in terms of some of the clients and patients and some of the populations of focus you all serve across, California. So let's start with a sample scenario where a community health worker. Now, remember, this could be, a health educator. This could be an outreach specialist. This could be, you yourself as an executive director who can function as a CHW. Pretend here that you meet someone named Miss Martinez, a 28-year-old transgender Latina woman, and she is someone with Medi-Cal. And perhaps you met this person at a local Pride event. Ms. Martinez recently relocated to the area and has temporarily paused her feminizing hormone therapy while getting settled. It's been some time since she has received hormone therapy. She shares that she's been feeling anxious and down, and she is looking for gender affirming, culturally responsive care after previous experiences of discrimination in health settings. So, this is someone who has had bad experiences with providers who were not culturally sensitive or inclusive. The CHW listens with empathy, offers affirming support, and explores options with Ms. Martinez to help her reconnect with care in a safe, inclusive, and welcoming environment. So this is our case study. So we're going to keep Ms. Martinez in mind as we go through the standing recommendation policy. So in this case study, on the left-hand side of this slide, the needs are recognized in terms of how they emerge. And so the community health worker at this, when they conduct an intake and they recognize that Ms. Martinez is eligible for CHW benefit services because of there's a list of eligible criteria for folks who are eligible for services, CHW services, and these are at least two of them. If someone exhibits anxiety and depression risk from past healthcare discrimination, that qualifies you for CHW benefit service. If they have a need for navigation to gender affirming care and integrated mental health services, that also provides uh, kind of provides eligibility for to receive CHW benefit services. I'm going to test you all later in terms of which of the eligibility factors Miss Martinez. So anxiety, depression, and navigation. So just remember those words. I'm giving you the answer in advance. And so, what the standing recommendation does, and this policy was enacted by the Department of Healthcare Services in April of last year. It's fairly recent, it's less than a year old. The authorization for your CHW to provide services is immediate. There's no provider referral needed under the standing recommendation policy. So, in this case, the CHW explains how navigation services, such as identifying and locating a gender affirming care provider, and also care coordination, just ensuring that appointments are being made and that the appointment is, ensuring that that's completed and any follow-up kind of care is conducted. The CHW explains that that's all covered by the Medi-Cal CHW benefit. And so as a result, Ms. Martinez is feeling relieved that someone understands the barriers in which, in this particular case, LGBTQ plus populations often face in healthcare settings. And she agrees to ongoing CHW support to navigate the care she needs. And so, and this, for this case study, we can, in the next module, we'll talk about how we can develop a care plan and what specific services that Ms. Martinez may need, and I described a little bit of it. Maybe it's accompaniment to the first medical appointment for advocacy and support. The CHW can get paid for that. Maybe it's, maybe there's a housing, a need or housing issue. So if the CHW provides a link to housing assistance, maybe Ms. Martinez is feeling some isolation, social isolation. So if your CHW provides a link to peer support groups, the CHW, your organization can get paid for that as well. Screening for depression and anxiety, that also can be a reimbursable service. So we'll talk more about at a future module, but the point of this case study is that the CHW can immediately authorize the services without any kind of approval needed.
I have a
John,
question,
your
Joe.
hand raised. Yeah, go for it.
What you yeah that the ability for someone to do immediate authorization, is that this is still with the understanding that the organization, should they already have that contract with the managed care plan to do this? Do they need that to do this?
That is correct. That is
Okay.
correct.
Okay.
So this is when the CHW is functioning as a qualified CHW, working for a CHW supervising provider. And so for your organization, if you when you complete the PAVE application to serve as a Medi-Cal provider to be recognized under the state of California, and you set up your contract with your local managed care plan or multiple managed care plans, then your CHW can deliver CHW services and get reimbursed for that Medi-Cal member that's associated with that managed care plan.
Okay.
Yeah.
Thanks.
Yeah. Go ahead, Amber.
Does this apply to people under 18 as well? Meaning like I know because they have to self-declare, you know,
Mhm.
but if we're outside of a school setting, because I'm getting because when they're for certified wellness coaches inside the school, you have to pre-authorize everything, literally. Like there's like 5 pre-authorizations. But outside of the school setting, if like a 17-year-old walked into our drop-in center, would the standing recommendation apply?
I believe so. That's a really great question. We're going to jot that down just to double check um, that particular scenario because we've typically talked about the CHA benefit for adult patients, but my knowledge, my assumption, yeah, my hunch is that the statewide standard recommendation can apply to beneficiaries who meet any of the CHW's eligibility criteria, and that's for all populations, so including children. And so, and for Medi-Cal members, knowing that Medi-Cal includes populations for children and youth under 21. And so I want to say yes. And that's actually true. I'm gonna just answer it concretely because we do work with First Five kind of organizations, and they work with a lot of children and youth, and they're already receiving CHW services. So yes, in this case, the policy does apply.
Okay, thank you.
Yeah, yeah. And I think generally speaking, for any service that's billed right under like a child's Medi-Cal ID, the child must be in some cases, I think in all cases, the child must be present when services are delivered. Um, and in terms of, I think there are just rules for particular clinics or particular managed care plans in terms of, um, uh, with the presence of parents and guardians and just making sure that the services are delivered appropriately. So that's something that I would just be mindful of in terms of
Mhm.
how that, yeah, in
Yeah, and
practice.
that's what we're really looking at, right? Especially with the LGBTQ population, because especially right now, lots and lots of young people are not super interested in having these conversations in front of their parents. And so we've
Right.
been really watching the school system when they try to figure out how to not batch upload Medi-Cal because you're not supposed to do that, but when they try to figure out how to get the pre-authorizations for treatment from the parents and from the providers, like how do we make sure that that the school isn't sending home something that says, hey, your kid wants to talk to somebody about gender affirming care when they haven't even come out to their parent, right? And so
Right.
those are the kind of things that we're just constantly thinking about is how are we going to make sure to protect a young person's um, privacy if they're not interested in having their parents be super involved, right? So,
Hmm. And I think in California, there's a minor consent.
yeah.
Yeah,
Luckily, we got lots of practice with that with our CRDP project. So,
right. Yeah, and the minor consent services, I'm just double checking DHCS's website here. Yeah, just anything related to yeah, sexual and reproductive health, care related to any kind of communicable diseases, including STIs, drug and alcohol, outpatient mental health, I mean, intimate partner violence. I mean, there's just yeah, I mean, youth can access right all of these services, and I think yeah, there's like this really great minor consent rule where parents and guardians they cannot be contacted right about the youth's receipt of these services. And so that's, yeah, that's really, really important to consider.
thank you.
Yeah, yeah, really great question. And Joanne, I'm going to encourage our team to kind of note that as an additional component of this curriculum to really review the minor consent rules and policies. So if we can add that, yeah, that'd be great. Thank you. So yeah, thank you, Amber. That's really, really important because that's something that has been brought up in our trainings. Um, right. So this goes back to the going back to the standing recommendation policy. We covered this earlier that the standing recommendation for CHW services for eligible Medi-Cal members, this was released in April 2025. So a lot of folks, managed care plans should know this by now. But just in case, we do encourage all providers to be aware that the standard recommendation policy exists, and the main purpose of this is to reduce barriers so that members can start receiving services immediately. We've heard anecdotes across the state where providers, before this standard recommendation policy existed, that it would take, weeks just to authorize, right, a service to be delivered for someone who is in immediate need of care. And because of this, they would be able to start instead of within weeks, they would be able to start within hours, same day or the very next day. And so this is just really something that's been a huge, huge benefit. Now, with that said, there are some restrictions to this, like with anything. So the authorization, it does allow for CHW services, allows up to 12 units of CHW services, and each unit is 30 minutes. So 12 units translates to 6 hours on an annual basis. So say, John is a CHW and I'm a client. John's able to deliver, his CHW services and provide navigation support and health education and screening services for me as a client for up to 6 hours every year. Um, and no initial provider recommendation is required. So, I can receive these services. Now, layering the annual limit, there's a daily limit too, right? John can only deliver 2 hours of services per day. And so that's 4 units technically. If we do 30 minutes per unit, that's 4 units per day is 2 hours. And so technically, say, John's providing services for myself, and I just need back-to-back services. Technically, my maximum kind of allowance would be 3 days, right? 2 hours per day for 3 days, 3 times 2 is 6, right? 6 hours, that's the annual. So after 3 days of 2 hours of services each day, that's when a care plan would need to be generated. Um, And so, and we'll talk more about the care plan, what that looks like, but in the future session, essentially, John would have to identify a licensed provider, whether they're in-house, right? If you have a licensed clinician in-house or anyone who's licensed in the practice of healing arts. Or if you don't have a licensed provider, then you'll have to find someone outside of your organization. You can establish a formal partnership with a local clinic, a local FQHC or hospital system, or just anyone who has it could be a private practice. Anyone can help sign off a care plan. And what we usually recommend is that folks to start writing this care plan like at the time, from the very first visit, so that you have the CHW who knows this client the best, right? They can develop a care plan that can be later reviewed and amended by the clinician in the future.
So Joe, the 12 units is what are permitted before a licensed provider has written a recommendation or care plan, so they can receive more than those, but after the care plan is in place. Is that right?
Exactly,
Okay.
exactly.
Okay.
Yeah, once the care plan is in place and it's been that has been signed off, then the Medi-Cal member can continue receiving CHW services beyond 12 units, and there's no maximum cap of units after that.
Okay. Thanks, Alex.
Right. And so for supervision, this is something we covered earlier that as far as supervision, you'd be meeting this supervision requirement once. This is, your organization being enrolled as a Medi-Cal supervising provider organization. In terms of documentation, here's a list of required information to document. So after a member receives their first, 12 units of covered CHW services for 6 hours, then yeah, a written care plan is, signed by a licensed provider. That's required. And the requirements for documentation include, the dates and time and duration of services that's provided to the Medi-Cal members, the nature of the service provided. Was it health education? Was it health navigation, screening, or individual support and advocacy? There's just four kind of buckets, right, of a reimbursable CHW service. And the length of time spent with the member. So the frequency and the intensity of the services are really important to document. I know for some organizations, this is something that is commonly not done, right? Just documenting in absolute detail. But for Medi-Cal contracting, this is absolutely critical. And I think not just a requirement, but a new skill that I think a workforce needs to learn, especially if they're not used to kind of documenting on this level.
Is there a software that we should use, or are there just like guidelines for how to retain documentation?
That's a great question. Every managed care plan will likely recommend a particular kind of way of documenting this. We've heard a mix of, kind of documentation requirements.
Okay.
We worked with one Medi-Cal managed care plan who made it really easy for CBOs, where they're like, you know what? Here's an Excel spreadsheet template. Fill it out and submit it through our, portal, and that's all you need. You don't have to, install some fancy, technology platform.
Okay.
And then we've heard the flip side of that, where a managed care plan would be like, oh, we're partnering with this technology firm, this platform. We'll pay for your user services for the first year. You'll have to train on it. You'll have to document through it and blah, 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 blah. So some managed care plans have that arrangement. We do have some providers who kind of, you know, pursue a new kind of, they have an existing documentation, like a case management, like documentation system, for example.
Mm.
And so they leverage that. They kind of tweak it to, be able to document these details. And they pull reporting and just for, just efficiency purposes, they can report and stay in compliance. I've heard many organizations try to adopt new platforms, but there are lots of risks associated with that. One, you have to kind of really assess like, do you really need this platform, right, for this particular service? My recommendation would be to have a conversation with your managed care plan, exactly what's
Mhm.
absolutely necessary. I find that, I spoke with one organization where they like spent like $250,000 like adopting a system, a platform, and they were like, this is not a financially sustainable program. And I'm like, in my head, I'm like, I can see why. You just
Mhm.
invested quarter
Mhm.
million dollars.
Mhm.
And I also see organizations that are kind of persuaded by for-profit technology platforms out there who have really excellent marketing and, appealing case studies like, oh, we'll guarantee that your organization gets billed, reimbursed 10,000, 20,000 a month. We can make this happen only if you sign up for $50 per user per month for a minimum of 2 years. And so, but, if you, and then those organizations that do sign up, very rarely from where I sit do I see that kind of benefit, right, actually happen. Because I see a lot of organizations struggle with the usage of the platform, right? It's like if you don't use the platform, it's not going to really work for you. So my advice is watch out, be aware, be mindful. There are so many ways of documenting it. I'm always a big proponent of let's start with a spreadsheet, with an Excel sheet. Let's build something, that aligns with your existing data governance, and try to build something that's not just uh, you know, good for reporting and to be in compliance with their managed care plan, but try to build something that's kind of agnostic and something that's, useful for your entire organization, not just for one service area, if that makes sense. So I hope that helps. I know that was probably a very long answer.
No, thank you. I appreciate it. Thank you.
It's kind of like the wild, wild west out there, y'all, with, yeah, there's a lot of for-profit entities kind of like, outreaching very aggressively to, CBOs and saying like, we'll save your day, we'll save your organization, leave it to us for documentation and billing, da da da. Da. But, you know, I would look at your own organization's strengths and resources and assets first and, and go from there. If you're gonna not saying that there aren't good technology platforms out there, if you're gonna look at a technology platform, make sure you do some kind of RFP process or RFI process. And I would always uh, get at least three, right? Look at three different platforms, get three different quotes, and always, always, always negotiate. Um, so, quiz time. Um, do folks remember Miss Martinez's kind of qualifications when we described kind of her story at the beginning of the session? So, I mean, this is a very comprehensive list of uh, eligibility criteria for folks who can receive CHW services. When any of the following is checked off, then they immediately, qualify for CHW services. But who remembers Ms. Martinez's kind of eligibility criteria?
Well, we can do this as a group, I think. She is a transgender Latina woman who recently moved to the area. Um, Stopped her therapy while she gets settled, her hormone therapy, um, and has not had good experience in the past with medical providers.
Mhm, mhm.
Good memory. That was a good recall.
It's early.
I mean, I think we know that there was a need for navigation and resource coordination. So that feels like the low-hanging fruit box. I guess I was wondering, just this would be a question if I was the CHW, is does missing your medication correspond with missing your medical appointments? Depending on the medication. That would be a question I would have, but
Yeah, that's a
That's
really
a good
great.
question. That is a good one.
Yeah,
And I think wasn't there indications of anxiety and depression as well?
right, right.
what's positive ACEs? I mean, are we using an ACEs screening tool or would just based on what we know about anxiety and depression?
Yeah, so
Mhm.
adverse childhood experiences, ACEs screening is a tool that you can use to identify trauma or chronic stress that occurs before age 18. So if children experience abuse or neglect or household instability, we know, I think research shows that that can provide long-term physical and mental health issues. And so ACEs does kind of it's part of it's one of many screening tools that a CHW can use, and there's a screening kind of service. And so, with screenings and assessments being a billable CHW service, if you conduct an ACEs screening, you can get paid for that.
Any ACEs screening.
Any ACEs screening, yeah. There is an ACEs screening kind of tool that's kind of standardized, and I'll drop it in the drop in the link here. But you'll see a link to specific screening tools. Let me actually drop in this link right here. So there's an ACE questionnaire for let's see. Whoa, there's a thunder. Like thunder rumbling in my neighborhood. Heard that in a while. So there's a pediatric ACEs and related life event screener, Pearls. This is so funny. We work with a group called Pearls, and it's for older adult population. So you will have to. So Pearls. So this is there's a Pearls child tool, a Pearls adolescent tool, a Pearls for adolescent self-report tool. So it looks like they have one in English and Spanish on this website. And then for adults, so this was adapted by a couple of organizations, Kaiser Permanente and the CDC. And so this is for adults who can also get screened for any adverse kind of childhood experiences um, in the past. So any kind of risk factors, that they experience prior to their 18th birthday. So like, for example, did you live with anyone who was depressed or mentally ill? Did you live with anyone who touched the justice system, things like that. So going back to this quiz, ding, 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 everyone's correct. So yeah, John, great memory of the case study. And Amber, you were absolutely right in terms of that there's a need for navigation for a resource connecting to a provider. We also would check mark in this case a suspected behavioral health condition because of anxiety and depression risk from past healthcare discrimination. And Joanne, if we can note that the missed kind of medication, if that could count as like a missed medical appointment, I think, Amber, that's a really great scenario. So we can look into that more. I'm not sure if there's a statewide policy around that, but I think I'm curious if Medi-Cal managed care plans, if they have like that kind of detailed guidance, yeah, in terms of what qualifies.
And then how are we measuring for unmet social needs? Is there a tool for that or
Yeah. I used to actually do this work a lot in the past. Let me recommend one tool that is used by the majority of federally qualified health centers across the country, and I've coached a lot of CDOs to use this tool. So in the link in the Zoom chat, you'll see a tool called Prepare. with an A, not with an E. But it's a long name. It's called the Protocol for Responding to and Assessing Patients' Assets, Risks, and Experiences. It's a really, really, really long name. But I was part of a national organization that partnered with multiple organizations to create these evidence-based, patient-centered kind of social determinants of health screening tools. And on this website, you'll see that this screening tool has been translated in over 20 languages, Arabic, like Dari, Chinese, Marshallese, Spanish, I mean, you name it, Vietnamese. So this screening tool is it kind of covers multiple kind of domains, your housing needs, utility needs, stress factors, food insecurity, your demographic information. Are you a veteran? Are you, do you identify as a particular racial, ethnic minority group? So all of these kind of risk factors are very comprehensive. So this is one tool that I would recommend personally. And Medi-Cal managed care plans, excuse me, Medi-Cal managed care plans are pretty familiar with this tool because they have a lot of medical providers like FQHCs and hospital systems that use Prepare pretty commonly. So if your managed care plan learns that you're a fan of Prepare, that you can use Prepare, that you can integrate this, they'll probably be more likely impressed and be very familiar.
We need like a flow chart. I'm constantly thinking forward about how I'm going to train all of our staff, right, to do this kind of work. And we're in various settings, right? I got some school-based family resource centers. We got the drop-in center for the LGBTQ and the foster youth. So I got an elder program. So I got lots of populations. And we almost it feels like we need like a flow chart, right? So like if you hit this button, use this screening. If you check this box, use this tool, right? Or whatever. Use this tool to check this box. I don't even know how it would look, but it feels a little daunting right now to think about how to it's one thing to get the CHWs the skills they need, the active listening, the motivational interviewing, all of that stuff. A lot of our staff are already doing this work, so that part's easy. But then how do we go from a checklist like this to making sure that the people on the ground that are trying to do the work know which box to pick and when and what screening tool to use and when and all that kind of stuff.
Yeah. Well, Amber, you must have, gotten a preview of this training in your
Oh, good.
dreams or something, because we're going to talk about workflows next.
Great. Fabulous.
So that's great. Wow, in the future, I'm gonna, plan to trainee to say this.
Yeah.
Gosh, I'm just thinking about workflows. It's like, well, here are the workflows. So we'll start with we'll zoom out first, right, in terms of we'll talk about referral pathways first. And this is just generally just kind of zooming out. There are a couple pathways, like in the top pathway in blue, a licensed provider, say, you have a licensed provider who identifies a member who they think, CHW services are medically necessary. And it could be, just anyone, whether it's in your organization or outside your organization, they can send that recommendation to the managed care plan. They can verify the client eligibility and assign that member to your organization because of alignment and population of focus that you serve. So if you partner with any systems out there, health systems, hospitals, FQHCs, and you can kind of establish this kind of referral pathway formally. The second pathway in the bottom of the screen is a licensed provider that you partner with or you have in-house, and you identify a member who they think CHW services are medically necessary. You can verify, right, the Medi-Cal member eligibility. You can do this by, looking up the, managed care plan portal that you're contracting with. And because of the standing recommendation, no authorization is needed. Your CHW can begin working on these services immediately, and you'll later bill the managed care plan for. So just want to zoom out and just kind of talk about the different pathways that could occur for referrals. we talked about the licensed providers who can recommend, right, CHW service benefit services. So they don't necessarily maybe enrolled in Medi-Cal or be a network provider within the member's managed care plan. So that's really awesome. So Alex mentioned in the chat earlier that a licensed clinical supervisor, they could be a volunteer. They don't necessarily have to be paid. So and they can be a physician, they can be a psychologist and a LCSW and an MFT, LMFT. They can be a podiatrist, so they can be kind of any kind of type of provider.
A quick question, Joe.
Yeah.
So I had this, I think this is a similar question I had the other day when talking to my our licensed persons. The way we're structured right now is we have a licensed clinical social worker who we have on contract. She supervises our full-time associate clinician. And so she's the person kind of with the NPI number on the individual kind of provider side. We're going for our NPI as an organization. What I think I'm hearing is, so does she have to be affiliated with the health plan that we are seeing people from, or does this indicate she doesn't?
She does
Like,
not. She does not have to be affiliated.
so even if she doesn't have any kind of affiliation or contract with let's say Health Plan of San Joaquin, she can still because she can still use her NPI number along with ours as the provider that oversees this kind of stuff.
Yep. Hmm.
Oh, okay, great, great,
Yeah.
great.
Yeah. Yeah, the managed care plan, yeah, they don't need to be enrolled in Medi-Cal. They don't need to be a network provider within
Okay,
the member's managed care plan. Yeah. So there's flexibility there.
great.
Great question. Um, and so that's great that you have an LCSW in-house. So you can definitely leverage them um for you know signing off, especially when it comes to the care plan. And I'm just double checking the DHCS all plan letter was updated a year and a half ago. Yep. In their words, the recommending licensed provider does not need to be enrolled in Medi-Cal or be a network provider within the member's MCP or employed by the supervising provider.
Okay.
They can be volunteer.
So if our associate clinician like develops the care plan, uh, they can have it signed off on by our LCSW, uh,
Mhm.
and it's still valid.
Right.
Okay,
And
great.
John, I just would add, even like James in the scope of his work could be doing, like he could be an um uh CHW, and the supervisor could review John's work in coordination with Albert's work in, like,
Okay, yes,
yeah.
great.
Mhm.
Good, good. Thank you.
And Joanne, I think just a note for our team, let's add the employment factor in there, like that they don't need to be employed. So we'll add that to the slide before we send it out. So yeah, so great question, John. Okay, workflows, Amber's kind of dream.
Mine too. Mine
Boom.
too.
Okay, so I know this is super blurry and you can't read anything on here. So I'm gonna switch over to our mural board and kind of go through and we'll send this to you all.
Thank you.
So this is I'll try to move as slowly as possible so we don't create any
Mhm.
dizziness. So screening to claim submission. So we call this our little like workflow from like the moment you screen someone to like, the final moment when you submit a claim and get paid for. So there are, right, different pathways in terms of where you can receive a recommendation from a managed care plan, right, or a licensed practitioner recommending someone, right, for a CHW service, or you identify someone, right, through outreach, like Miss Martinez. The CHW would conduct a new participant intake, right, kind of documenting just like who they are, their demographics, their immediate needs. Um, and then the CHW would, ideally conduct eligibility and enrollment verification, right? Making sure they're a Medi-Cal member of the managed care plan that you're contracting with. If they're not enrolled in Medi-Cal, then that's an opportunity to do eligibility determination enrollment. You get paid for that. Um,
Can
the
we another question? So
yeah.
we just became aware of the Benefits Cal website that allows both an organization or a new insurance member to sign up for Medi-Cal. So we could, and if I'm hearing this correctly, if that person has not yet signed up, we could also help them sign up, and that would also be a CHW type of reimbursable service.
Yes.
Okay.
I think yes, for a CHW helping with enrollment
Mhm.
and especially with the new redetermination kind of requirement that's coming out,
Oh,
right,
right.
every 6 months. So
Every 6 months,
that would
right.
be, yeah. So anything that has to do with like application assistance, eligibility determination, not just redetermination every 6 months, which is crazy. Like it's every 6 months is like just
Oh, it's ridiculous.
I
We
know.
know.
And the work requirements on top of that. I mean,
Mhm.
there's just so much. So the state is actually they just rolled out recently a really big implementation plan, kind of calling out like, gosh, we really need community health workers to like do all this work. And
Mhm. Mhm.
so yeah, you can get paid for
Okay.
that. So after you conduct the verification for the eligibility and through the portal, and the standard recommendation allows, right, that you all to kind of conduct this eligibility and conduct screening right away. So these are the examples of the screening that we covered earlier, right? We have Prepare that you can use for SDOH screening, you have ACEs screening, and so there are different types of screening that you can conduct. This blue means that you can get paid, right, for the moment you screen. After that, what we typically recommend is that we start, CHWs to start drafting a care plan, right? Even though this is not required, right, until after 12 units of service, right, after 6 hours. But it doesn't hurt. It doesn't hurt to draft a care plan, just documenting what their risk factors are, what their required services are. Is it to address a behavioral health issue, chronic condition, or maybe they need navigation. And then the CHW can, later on, right, especially after 12 units, share that with the license provider to edit and sign. And then you would implement the care plan. And so the care plan, these are the three other billable services right here, right? Health education, navigation, and support and advocacy, right? So you already got paid for screening and assessment, but now you have the three other buckets. So in this case, if you're providing health education, the CHW can offer a menu of services related to whatever education is needed. For navigation, say, for example, it can provide your resource directory for all the partnering organizations out there related to housing or, food or utility support. For support and advocacy, this can come in the form of different things like accompanying, like, the client to a doctor's appointment, for example. Um, for going back to the navigation support, you can see that not just you're offering a resource directory, but you're completing a referral form. You refer the client with a warm handoff, and when you confirm that the client receives the outside service, then you can, mark that as a successful navigation kind of support service.
I have a question about this too. What I was reading, or yeah, what I was reading, I know that if I understand this correctly, for CHW, like the supports and those kind of work, doesn't Medi-Cal, isn't it a flat fee reimbursement per client that you receive, or is it? Because I was told there's a distinction between like when we provide our mental health counseling services, which we have to kind of do in another kind of way, that's more reimbursed on a per session type of
Hmm.
basis, whereas supporting patients through the CHW type of service is more like you get reimbursed on a per patient per month basis. That's correct?
So
Or
Medi-Cal does have different payment arrangements where for the CHW service, it's a fee for service where you get paid for every 30 minutes of
okay, okay,
so and each unit starts at for individual service, it's $26.66
okay,
baseline. That's for individual CHW service. But when you do a group visit, the reimbursement is less.
okay. And I
But
think I'm getting it confused with the enhanced care management piece.
the enhanced care management and community supports, they have like a capitated
Right. Okay.
like per member per month, right? So
Gotcha.
yeah, and their reimbursement is typically higher. Um, but and that makes sense because you're dealing with really complex care, right?
Right.
Management for folks who qualify for enhanced care management, like those experiencing homelessness,
Right.
justice involved populations. For CHW services, while the rate is not as, fabulous, $26 ish per half
Is that
hour
per half hour?
per half hour. For yeah, it is per half hour. For some, it's sufficient. For some, it's not enough to cover, the salary and overhead and things like that. One thing to remember is to always negotiate with your managed care plan. Always ask for a higher rate. I've met organizations where they have received a rate that's so phenomenal that they had to sign an NDA to not disclose this rate because they're receiving so much money per half hour. And I'm like, please tell me that I signed an NDA. I'm like, well, I'm happy for you. So if
Okay.
you justify, right, like with your data, the needs of your population, and tie it to how you can help that health plan improve their measures, right? Their kind of health
hmm
measure that they're
hmm
struggling with. And so that's something that we really want to just emphasize. And so,
Thank you.
and
Joe, I'm so sorry. I have to jump off. I have another.
no worries. And I just realized it's 10 o'clock. We're going to wrap up in just a couple of minutes. But Amber, please hop off.
Okay.
We'll follow up. Yeah.
Okay, thank you. Bye.
Bye, Amber.
Um, but I'll send this kind of workflow later as a tool for everyone. But basically, the last step here, John, is to document, right, in your care management database, and then you bill, right, and then you
hmm
submit it, and then you get paid.
hmm
So that's the flow. So that
hmm
concludes our our training for today on this particular topic.